Hey everyone, this is Victor from Cyborg for Life, and today I have another special interview. She's the Director of Rehabilitation at the Paley Orthopedic Spine Institute in West Palm Beach, Florida. Please enjoy the interview with Dr. Fran Guardo. All right, everyone, today we have a very special guest joining us. She is the Director of Rehabilitation at the Paley Orthopedic Spine Institute in West Palm Beach, Florida. With years of experience as a doctor of physical therapy, it's no wonder she's part of such a world-class team led by limb lengthening legend, Dr. Paley. Trusted to oversee the crucial physical therapy and rehab department and caring for thousands of patients with a multitude of orthopedic conditions, including limb lengthening. If you're lucky enough to be treated by her or her team, you'll know you're in good hands. Please join me in welcoming Dr. Fran Guardo. Hey, Dr. Guardo, how are you? Yeah, definitely. Thanks for coming on the show. I think that this is going to be a really interesting interview because of the fact that we can highlight a different aspect of limb lengthening, the rehab, which is super important. So, Dr. Guardo, you have extensive qualifications, great background. You have both a master's and doctorate degree in physical therapy. You're a BS PTS level 2 certified for special treatments such as scoliosis. And you're also a master's in education, which allows you to teach other therapists and medical professionals how to handle a variety of complex conditions, all of which you handle wonderfully at the Paley Institute, including limb lengthening, which is the topic of today's discussion. So to start us off, I just want to get a brief background of like how you went from being a traditional physical therapist to being in the field of limb lengthening.
Mm-hmm. So I was practicing here in West Palm Beach. I was actually practicing on the island of Palm Beach, and Dr. Paley was moving his practice to Florida, and his folks contacted me. So I guess that they had kind of, I don't know, they'd been looking, doing some headhunting in the area, and somehow my name popped up a few times. Dr. Steve Sylvester, who is a professor in exercise science at the University of Palm Beach Atlantic, and I had worked together on several occasions, and I think he knew someone who knew someone, and anyhow, so they, Dr. Paley and I had a few conversations. We talked. We got along really well. We had, you know, like-minded ideas, and he took a risk and I took a risk. And so I have had the distinct honor and to build the Paley Institute Rehabilitation Department literally from the ground up. When I first walked in and toured the building with him, there was nothing, just a few boxes on the floor. And we're in the Kimmel building, which you don't know what it is, but it's a building on the campus of St. Mary's. And we had like this really small department of it then. And he says, we will have this building by the time, you know, in a few years. And in fact, we do. And now we're expanding to other buildings, and now we have branches in other places as well. So,
wow.
Yeah.
That's amazing. Yeah. That's a really cool background. And yeah, so Dr. Paley actually reached out to you. That's really, really amazing. I mean, someone of his status to bring you on, and you said took a risk. I think you're an amazing physical therapist. So yeah, so Dr. Guardo, when a patient gets limb lengthening done, whether it's for stature to get taller or fixing a limb length discrepancy, or even something as severe as congenital femoral deficiency, it's important that they know how important physical therapy and rehab is, because we all know that it's not just about the surgery. It's not just one and done, but the recovery and the rehabilitation is what guarantees a successful outcome. So in your words, why do you think physical therapy and rehab is so important?
I think it's important in many different aspects and surgeries, but it's particularly in limb lengthening, because in limb lengthening, it's not like you have your surgery and then you get better every day.
Right.
Your surgery, you have some type of implant, whether it's an external fixator or an internal rod that telescopes and lengthens, such as the PRECICE or the Stryde, or in the early days when we opened, it was the ISKD, which I know Dr. Paley talked about a little bit in his. We won't go there because it's not really used anymore. But so then, you know, you have a week to kind of heal a little bit, feel a little better, and then they start the distraction.
Okay.
And the bone starts distracting, which is really quite the easy part, because the device distracts and lengthens the bone.
Right.
the soft tissues get dragged along and kicking and screaming sometimes. And that can, in fact, be the limiting factor. So we as physical therapists and occupational therapists, because also folks lengthen, you know, they have a limb difference in their arms and or bilateral short arms or whatever. But so we also lengthen arms. So whoever the therapist happens to be, occupational, physical, we are lengthening the soft tissue. And what is the soft tissue? Skin, fascia, nerve, very important. You know, vascular, muscles, tendons, all of that has to lengthen too. And if that doesn't lengthen, it tethers the lengthening and it can create havoc. So physical therapy, occupational therapy, therapy in general is very, very important, but so much so in the limb lengthening process. It's not going to be successful without it. I've seen people come to our center who have had lengthening in other places, whether it's unilateral or bilateral, and they didn't do the therapy. And they come to us, unfortunately, and unable to function. They've perhaps lost their ability to walk, or they've got a limb that no longer functions as a limb should function. And you know, we've had to fix that. Sometimes it requires surgery. Sometimes therapy can get them through that and get it going, and they're okay. But anyhow, so it's vital. And very, very few therapists have any experience with limb lengthening. I can certainly tell you, before I came to the Paley Institute, I didn't. I worked. I had a very extensive background, and I'd worked. I became an exercise scientist many, many years back. So I understood exercise physiology. I understood, you know, all the things that go with that. And then I became a physical therapist, and then went on for the specialties. But one of the populations that I had worked a lot with was pediatrics and pediatric neurological. And when those kids go through growth spurts, or when kids in general go through growth spurts, what happens? They develop some of the contractures and some of the things that you will see in someone who's undergoing limb lengthening. Why does that happen? Because that's when tissue becomes tight. And so the background I had made me at least understand, oh, this can get tight, this can dislocate a hip, this can get tight, this can dislocate a knee. Why? Because I actually had seen it in some of the pediatric populations that had neurological issues. And so it made total sense. And I actually remember one of the very first conversation with Dr. Paley, we talked about that. You know, I talked about, I bet that's at risk. I bet that could happen. And he said, yeah. So anyhow, so I came on board, and there wasn't a lot out there on the physical therapy of limb lengthening. There really wasn't. And so we were kind of flying the airplane as we were building the airplane, right? And so anyhow, so it's very important in the process of limb lengthening that we continue growing the tissue so that the bone and the tissue can grow safely and maintain the joint range of motion, and not sacrifice function for length.
Ever. Yeah. You now know the type of conditions that if a therapist is not trained in limb lengthening, then potential conditions can just arise left and right. So that's why you guys are probably so successful at the
Well, I also want to give credit to Anil Bhav, who was the director at the Rehabilitation Institute. And he's amazing. Really amazing. He has helped along the process. In the early days, there wasn't as much communication, but there have been later, and there has been later rather. And so, you know, there were other programs out there doing it, but there wasn't as much communication in the early days. And you know, one of the things that I have done as the director is I've tried to create programs that educate other therapists. So I've actually created a limb lengthening and deformity correction course that runs every year, except for this one because of COVID. We'll get it going. We may be virtual, but we'll get things going again. But anyhow, that it's an entire week-long program that people come and we present on limb lengthening and deformity correction, because it's not just, you know, every surgery and distraction with an external or an internal. It's not just for gaining a longer limb. It's also for correcting deformities. And again, most therapists haven't been exposed to that.
Right.
And I want to make it less common that there are secondary problems that occur during that process. I mean, people come to doctors and things like, and surgeons for correction of it. And so there need to be more people that know how to rehabilitate it. So anyhow, we have our annual course. I believe we started that in 2012. And so other people don't have to go through such a struggle to get their programs up and running.
I see.
And we host therapists from around the country and around the world to come do a preceptorship with us, so that they not only attend the course, but they're able to come and be in our clinic and observe. No hands-on, but observe, and get a better understanding of what it entails.
Wow. So like this visiting physical therapist conference that you have every year annually, that's, so you said it, obviously this year because of COVID, you haven't had it, but you're still planning to do it virtually. Is that it? Is that right?
Yes.
Maybe. Okay, good. You got to do it.
I just said that on YouTube, didn't I?
Yes. I got to hear.
Build it and they will come. Yes, we will do it. I'm not sure it's going to happen in 2020.
Okay.
Happen again in 2021.
Right.
But,
okay. Very cool. Awesome.
We will definitely continue that tradition because it's vital. It's vital.
I think so. I think that more and more therapists, I know for certain that the field that I work in with a lot of physical therapists and whatnot, they know nothing about limb lengthening. I talk to them about it, like, what's that? So, you know, that makes that point super, super clear.
It's not taught in school, except for I'm an adjunct at Nova Southeastern University where I did my graduate work or part of it. And I do some teaching there and I do guest lectures other places. So it's getting there.
It's getting there.
Publish more and get it out there.
It's moving around the field a little bit. That's good.
Because I don't know if you're aware, but most of the people that come to our center have been told that amputation is the only option.
Yeah, I have heard that. And that's what Dr. Paley mentioned. And then you guys are, you know, salvaging limbs on a daily basis, you know, and saving them from both physical therapy and the surgical front. So it's amazing what you guys do. And I was so glad when you were able to come on. So, yeah. Dr. Guardo, when a patient, like a limb lengthening patient actually starts physical therapy, let's say obviously they have the surgery, and then you said that they're going to wait a little bit of time and then they're going to start distraction. When is the first contact of when physical therapy starts? And then can you take us through the process of when they start, the process of what it's like, and then when they're discharged, and if they need therapy, you know, after that, or do you just stop at a certain amount of sessions and say, hey, you're on your own? How does it work?
So actually on post-op day 1 in the hospital, they have usually their first session.
Okay.
So the goals of a hospital therapist and an outpatient therapist are slightly different for the patient. They are wanting to get them moving, wanting to get them, you know, moving around in bed more independently, or if it's a little child, having parents feel comfortable moving them, getting them up to a chair, getting them, you know, to do their daily functions, going to the bathroom, things like that. So that starts post-op day 1. They also start a little bit of range of motion as well. Not as aggressive as when they come to outpatient because, you know, they're acute. They also try and get them off pain meds and whatnot in the hospital or onto oral pain meds instead of IV pain meds. So it starts post-op day 1. And then their goal is to get them up and out of the hospital as soon as possible so they can begin outpatient physical therapy. So in our center, we've never had a waiting list.
Oh, wow.
That's a lot to say, especially during COVID and everything else, but we've never had a waiting list. We get them into our center between 24 and 48 hours after discharge from the hospital.
Amazing.
So, it's a lot of juggling. Our schedulers are Brilliant. It's not always seamless and it's not always pretty, but everybody on our team does their part. And our therapists are amazing too, because that doesn't happen without a really dedicated team that says, I'll take that late patient, or I'll come in early to take that patient, or we're open Saturdays as well. Yeah, I'll take an extra Saturday patient, or I don't mind working the Saturday. I can't say enough amazing things about my team. They're dedicated, they're caring, they're brilliant, they're amazing.
Wow. That is definitely. I definitely want to really break down the amazing team you guys have and the structure there and why it's so successful in a little bit. That really cool. Because you don't hear about that at most centers. You hear about maybe, they have a great surgical department, but the therapy department is what is key. So I love that you told me about that. Dr. Guardo, can you talk a little bit about the differences between a patient who uses something like an external fixator, like a ring fixator or a monolateral rail, versus something like the internal lengthening nails like the PRECICE and Stryde, and the differences between those two nails? Because we know that one is, allows more weight bearing than the other.
Absolutely. So somebody that's going to require an external fixator usually has some other type of deformity. It's not just the length. Okay. Right. And they need correction, they need more correction, or they need stability across more joints. Okay. So if you have an implant like a Stryde nail or a PRECICE nail, then you're going to be mostly correcting length. They can do some correction otherwise, but it's much smaller. Okay. Or you need stability across the hip. Let's say you've got somebody with one of the conditions that we treat a lot called Congenital Femoral Deficiency also, and they have a hip that's precarious, that's at risk of dislocating. Right. But they have a very short femur too. They absolutely have to lengthen. Okay. So you can actually cross the hip with another type of fixator, with another add-on to the fixator. So you have an external monolateral rail on the femur, then you cross to the pelvis, right, and then you hinge so that can move, and you have secured the hip, so it's not going to dislocate with the lengthening, or so that you can just maintain that stability. Also, let's go back to that child with CFD, congenital femoral deficiency, and their knee perhaps is not stable enough to lengthen with a PRECICE or a Stryde. So they need to cross the knee again and hinge it and maintain that stability. So, or they have deformity, let's say of the tibia, and they have multiple things, a different child, maybe one with tibial hemimelia, or maybe one with fibular hemimelia, and they need to correct the deformity before they lengthen. Right. So somebody like that is going to need the external. Okay. And then somebody who's got less deformity to correct, perhaps it's just a short limb, and there's not a just in front of that, but perhaps because it's not just it's a big thing, but it isn't varus valgus. It's not as many things. There are not as many things going on. Right. So somebody that has something less can use the internal. Now, also, they may need for their first surgery an external. Okay. And for the further surgeries down the road as they grow, they may not need that external the whole time. So they may transition to an internal at the next one. Okay. Yeah. And sorry, backing up to how that differs in therapy, the external is a lot more painful. Yep. Because you've got the pins going through the skin into the bone. It's tethering the tissue. It hurts. I know you've undergone a limb lengthening. Did you have an external or an internal? I had an internal. However, I did have a broken femur from an accident, and I did have an external monolateral rail. And I can tell you from experience, it is much more painful for physical therapy. Yes, absolutely. Yeah. And with the external, it's interesting. So we started with external and then the ISKD, which we won't talk about a lot, but the ISKD did not have an external remote control. Okay. It had pole changes in the magnet based on movement.
Ah,
So
yeah.
sometimes you get runaway nails, and sometimes you get all of your length in just this little short period of
Oh
time.
my God.
It was disastrous. It really was, but it made us all better therapists, right? And so my point is, there weren't a whole lot being used because it wasn't a great product.
Right.
PRECICE and Stryde,
Amazing.
amazing, yes. And it makes the whole process so much easier. It makes our job a lot easier, but it's still not easy.
Yeah.
But my point was, so with the external fixators, you tend to see tightness more, let's say in a femoral lengthening, in the quads. Why? Because it's tethering and it hurts when you bend. It goes through that tissue.
Right.
And with the Stryde, or rather it started with the PRECICE, you know, you kind of are expecting when you have a new product that it's going to behave pretty much as the old product. And then we're realizing these hamstrings are getting a lot more tight than the quads.
Right.
The pro knee bends were really quite easy with the PRECICE nails initially, but the hamstrings were getting tight. A couple reasons: we didn't have that that knee bar that you would put in with that external fixator. And so you just have to develop other things that are going to do the same thing. So now we know in certain populations, not all. So if you have a short femur because you had a growth plate injury as a child, you're not as at risk as somebody with congenital femoral deficiency.
Right.
Right?
Yes.
So so not everybody with the femoral lengthening needs a long leg brace that holds the knee in extension at night. Not everybody needs that.
Right.
I'm guessing you probably didn't have one when, yeah. So, and folks that are undergoing, like we do have a stature population that is undergoing lengthening bilaterally, and they don't need that on the femurs.
I see.
Because their anatomy is normal. Right?
Yeah.
But there are areas that still need to brace. Like if somebody's undergoing a tibial lengthening, they absolutely will need a brace to maintain that foot at neutral, so that posterior chain, that gastroc and the soleus, so that they grow at the same rate that the bone is growing.
Absolutely. I definitely know that for my tibial lengthening, my Dr. Conway, she gave me one of those night braces for the tibial lengthening, not the external fixator, but and it was for me to wear at night just to keep that foot at neutral, even though it still got tight, you know, because you're lengthening tissues. So very, very cool. So yeah, you would say that these internal lengthening nails, you said that they're a game changer in terms of therapy. They make it a lot less painful. Would you say that the Stryde Nail for, you know, patients who are able to weight bear and do walking gait exercises, has that improved upon the PRECICE nail?
Absolutely. The PRECICE nail, you were able to weight bear, but you had lower limits.
Yes.
So the first PRECICE nail only allowed 50 pounds of weight bearing.
Yeah.
You had that one.
Yeah, I had that.
We allowed weight bearing. We would teach 50 pounds. What's it feel like to put 50 pounds on that? So we would bring out scales early on and have them shift weight and have them look at the scale, shift over, look at 50 pounds, look at 50 pounds, you know, teach that. And then we'd have them look up. We still do this for folks because we still use PRECICE nails. Not everybody's bone can accommodate the Stryde. Right. We lengthen little kids with PRECICE nails. Not all of them are going to take a Stryde. Not even all adults can take one. Some adults have very, very tiny bones. So, anyhow, so we were teaching what it felt like to accept 50 pounds. Right. And then they made a better Stryde or a better PRECICE nail that would accommodate 75 pounds. So there's still a 50 pound and there's still a 75 pound. And now there's a Stryde. So we had folks weight bearing on those early ones, but we were teaching them so that they could
gauge how much it was.
Yeah. So we honestly, I hope I'm not misspeaking, but I don't remember that we always allowed them to weight bear. Folks that were bilateral may not have been walking depending on their weight, but they were at least doing pivot transfers. But that said,
that's amazing.
Of course, as Stryde Nail came along and they could take higher and higher weights. Absolutely, it's been a game changer.
Wow.
People can be walking with just a cane. And why? Not day one though.
Right.
Still come out of the hospital. Life ain't so pretty for a little bit. It's very uncomfortable. But you're up on a walker and you're walking. You may be using wheelchair for distances, the first bit. And even, down the road, once you're on a cane, you're probably not going to go around Disney World on a cane. You may take your wheelchair for that, but you will certainly be going around your home, shorter community distances. Maybe you'll be doing them all with the cane, but you carry the cane if you're bilateral. If you're unilateral, you don't need the cane.
Okay.
If you are bilateral, why do you have to have a cane still? Well, because walking is not exactly the same as standing still or even standing on one leg. You're putting some impact, which increases your forces. And let's say you're going up steps or down a hill. And so it's just that extra little layer of security. And again, it's for our bilaterals. Our folks undergoing unilateral limb lengthening usually are walking around without any assistive device, at least for short community distances and home.
I see that. Wow. That is amazing. So just seeing the changes in these devices, I mean, the evolution alone has literally pretty much made this field, changed completely. So now,
wait, I'm not sure I answered your original question. So how does that make it better? Yes, they're walking more, but as you and I both know, as you're moving more, your muscles don't get as tight.
Right. Yeah, so that's huge.
You're not losing as much strength. You're not having as much atrophy.
Yeah.
You're moving them through their more normal range of motion.
Right.
Do they get tight? Yeah. They still get tight. Even with great therapy, even with everything. Lengthening 1 millimeter a day. Yeah. That's faster than physiological growth is going to occur. And we even know with physiological growth, you can get tight. So they're still going to have some tightness. Right. But not to the same extent. And not the same extent of pain, because when you become stiff and when you become atrophied, everything's more uncomfortable.
Oh yeah, definitely. And that's what I remember from the external fixator and everything. And I remember Dr. Paley said that, until we come out with a nail where people can walk and do their daily activities a little bit better, this procedure is not going to become popular enough. And now it has, and look at how, popular it's becoming. So very, very cool. Dr. Guardo, I want to kind of touch on the topic of maxing out the length of the internal nail. I know Dr. Paley said that it can go up to 8 centimeters, the PRECICE and Stryde nails. And a lot of patients who are, let's say, undergoing stature lengthening to get taller, their muscles are going to get taut and tight. You said it, soft tissues, fascia, tendons, everything else. Can you talk about the type of pain or discomfort they're going to have when they get tight during physical therapy? Because obviously we know manual therapy is going to be, a battle as they approach the end of their distraction phase, versus when they're done therapy and they have to continue doing exercises on their own. Can you just kind of talk about that process of like the discomfort or the pain or the tautness that they're going to feel? Because a lot of prospective patients are always worried, like, oh my gosh, I have to go through this pain of, everything like that. Can you give us your perspective?
So, yes, it's uncomfortable.
Yeah, it's uncomfortable.
I personally have not undergone, so I can tell you what I see people feel, but I cannot speak to it as you can.
Right.
So let's be clear about that.
Okay.
So it's hard for me to tell you exactly what they feel. And even your experience is going to be different than someone else's.
Absolutely.
Because we all experience pain differently. Pain and anxiety feed upon each other. So somebody that's very, very anxious may perceive their pain as more intense. And it's not a misperception. It's not to say that their pain isn't that intense. It is that intense. But there are many things that we do to decrease that.
Okay.
So if you're gradual with your progression of movement in a therapy session, and if you teach them starting day one, okay, first day, These are the things you should be doing at home.
Okay.
If you're only coming to us for an hour and then you're not doing the things at home,
Right.
that hour is going to be a lot more uncomfortable than if you're doing those things throughout the day that we've taught you to do.
Okay.
Guaranteed.
Yeah.
But let's assume best case scenario, you listen to us day one and you're doing all those things. Okay, so that's the first step in the program of having less discomfort.
Okay.
Promise.
Doing your homework.
And the second step, once you get to therapy, we're gradually, the whole session, the whole entire session is progressive.
Okay.
So you may come in and you may start on something like a seated stepper or maybe even a standing elliptical, something that's going to help you begin your motion, warm up the joints, warm up the muscles, warm up the ligaments. We may even throw, if you're on a seated stepper, we may even throw a hot pack over your quads if you're lengthening quads, because it feels good. It increases blood flow to the area, increases heat, whatever. We're going to be progressively increasing your motion throughout the session. So the second thing you may do is going to be a little bit more motion than that first thing. So maybe we have you doing some standing stretches. Maybe if you're lengthening tibia, tib fib, maybe you're going to do some gait training where you're increasing your step length. Maybe you're going to do the wedge stretch where you're getting your heels down on a wedge and you're stretching that gastrosoleus. You know, it's going to be progressive. Each step's going to be a little bit more. Or maybe you're further along in that process and you really need to start with some soft tissue stuff for that second step of therapy. So maybe we're going to be using ASTYM tools on you. Maybe we're going to be using our hands on you and continued heat. And then we're going to introduce progressive stretches. So again, the first stretch is not going to be the most aggressive stretch. We're going to start with the one joint muscles first. Okay. And then as those loosen up, then we're going to progress to the two joint muscles. Okay. And so each stretch builds on the last stretch. And by the end, then you're doing the really, really hard stretches, but it's not as bad as if you come in and that was the first stretch we went to. Absolutely. So everything builds on itself. Everything prepares you for the next step. And by the end, we're doing the really hard stretches. I'm not going to say they're not hard. They're still hard. But they're not as hard. I see. And you're ready. And it's painful. It's painful. I don't want anybody to think that they're going to come in, they're going to gain 8 centimeters and have no pain. They're going to have discomfort, but it's manageable. And we work with you every step of the way. And a lot of it also has to do with what the patient does when they're not in our center. Absolutely. I think that you've nailed 2 important points down in that what you just said. It's one, the progression. I think that's super important because I know for a fact that when I came in, I did exactly what you said. It was always warm up. Then they started off with the single joint muscles and then the multi-joint muscles. And by the end of it, I felt like I could walk normally, you know, and then obviously I'd come in the next day a little stiff and then it would just kind of warm up and then it got better and better. And then you also said that doing homework. You're essentially giving the patients homework to do at home, and it's vital and crucial that they stay very compliant and do it on a regular basis so that when they come back in, they're ready to take, you know, for the next lecture, essentially, what you guys are doing and moving forward along the therapy and rehab process. Amazing. I love that. That's really good that you're highlighting that so everybody can get an insight into what you guys are doing. And part of that home program is wearing their bracing. Okay. Yeah. So if you're not wearing your dorsiflexion splints that are on the ankle and you're only wearing them a couple hours a day, I don't care how much other stuff goes on, that gastrosoleus is going to get tight. Absolutely. If you have CFD and you're not wearing your brace, it could be very bad. So you have to do what we've said to do. We're not making it up as we go along. And we haven't put these things in place to torture anybody. I know it's not fun to sleep with the brace. I know. I have a hard time sleeping with the retainer. I can only imagine, okay? But if you don't do it, you pay the price. And you may not get all your length.
Yeah, yeah. I remember that's what several surgeons have said. It says, look, if you're not doing your therapy to keep those muscles pliable and loose along the process as your bone lengthens, then you may cut yourself short, and it's like, or get a complication in the end. So it's vital and important that you do that. Amazing.
We're not going to sacrifice length for function.
Yep, there it is. That's a consistent theme that I want you to really keep driving home. That, hey, look, a lot of people are saying, oh, how tall can I get? They're missing the point. It's like, how tall can you get safely, and come out of this thing the same thing as you went in. So, Dr. Guardo, I have a lot of data from a lot of the videos that I do that interested patients in stature lengthening to get taller are 85% male, 15% female, between the ages of 18 and 34. And a large portion of these people are, involved in some sort of athletics or physical activity. And so I get tons of questions from fitness enthusiasts all the time saying, oh, will I be able to get back to my sports and my athletics? Do you guys have specialized plan of cares for these individuals? And what type of expectations do you set for them? Do they match up with their expectations, or do you have words of caution to these people?
Good question. I'm actually really happy that you answered that, or rather that you asked it. Undergoing limb lengthening to get better at your sport, not a good idea. I've actually heard in other countries when I've lectured, I've heard patients tell me that someone said that because their limbs will be longer, they'll be better at. No, please don't ever undergo limb lengthening for that reason, ever. There's definitely going to be a time where you're not able to practice your normal sport.
Right.
During the distraction process, I don't care if you have a nail in that allows you to weight bear 200 pounds, and you are not going to be practicing sport. Okay. You are going to be hopefully doing all the things we say. But there's also, or if you even have an external fixator on, you're still going to need, there's going to be a time where you don't do the sport you like to do. But if you rehab, if you allow your bone to heal, if you strengthen your muscles and lengthen your muscles through the stretches, and you follow all those guidelines, you will get back to sport. It may take a year. Right. And it may take 2 years until you're where you were at. Yes. I don't have that magic crystal ball to tell you when you're going to be where you were at. Right. I wish I did. Yeah. It depends on how much you put into it. And sometimes it depends on how much you don't put into it. Yeah. Because I have seen people go home and know. This was back in the days where, I've seen people with the PRECICE, like the PRECICE 2, know that they weren't supposed to walk without a walker and do it anyway and have problems. Yeah. It's published. It's published. But I don't have to go into great detail. You can get into very bad trouble if you don't pay attention to the guidelines. So maybe you have to back off of things for a bit, right? And let's also take a second to talk about what types of exercise are okay to do with a nail and what types are not until your bone has bridged. Okay. Okay. Yeah. So you can do open chain activities and you can do closed chain, but you can't do closed chain activities. Open chain is meaning you can do leg lifts. You can do things like that. You can do pool. You can do walking. Right. You can do things that create an axial load. Okay, so here's the nail. Okay. Begins to distract. All right. The bone begins to distract. You have a nail in there. Yeah. But you don't want to put it in a position that torques that. I see. Regenerate. Yeah. Because that nail is built for an axial load. Right. So are you going to be doing weighted squats? I hope not. Yeah. Are you going to be doing heavy weights at the gym? No. Are you going to be doing running and jumping? If you are, you're going to have a problem. So you're going to have to know how to follow the guidelines.
Yeah.
But there are a lot of things you can be doing, but you
Right.
have to allow the healing before you build back all that muscle. You won't lose as much muscle as you would have in a device that allowed less weight bearing. But you will lose, if you're a power athlete, you will lose some of that. You'll have to build it back. And once it's safe and you have the okay from the docs, oh yeah, now you can begin that. You know, now you can begin your running, jumping. Yes, now you can begin your squats.
Yeah.
First you begin weighted or non-weighted squats, and then you'll be allowed to do increasing weight when your belt has bridged.
You're making an amazing point. You're basically, you guys really make it clear of what they can do, but also what they should not do, which I think is important for limb lengthening, because a lot of people think, oh, as long as I just do what they're telling me to do, but then they get comfortable and they start doing things against the grain. And then that's when the problems occur. Things like, obviously, like if a person's in combat sports and they start stretching funny or something, they can have problems because there's different forces and everything like that can cause problems. So you definitely want to just do the axle loading, closed chain, and open chain movements like you guys say, but at different stages, as I expect. It's not going to all happen, you know, within the first 4 weeks. It's going to probably be a little, different. So
I get a lot of folks that come, especially my stature folks, when they're feeling better. Can I go to the gym? Can I do You can not do the things you used to do right now. There's a time and a place.
What about like doing like if upper body exercise? I know a lot of guys are like, well, I'm cool with not training my legs, but can I lay down or sit down and do curls or train machine work? Yeah,
they can do that as long as they're not carrying heavy weights. The bench or standing with, you know,
big plates and stuff. And dumbbells.
Absolutely. If they're on a machine and they're just moving a pen then they're sitting to do that, there's no reason they can't do that.
Very cool.
But you have to always be thinking about the load that you're putting on there. And if you're sitting down to the bench with 100 pounds in your hands,
how are you gonna get up? Unless you have a partner, then I guess, you know, but in that case, you shouldn't even get
you can do. You just have to think.
You have to be careful.
You have to think, and that has to be in your mind with everything, because again, if you do harm, then it's going to take you longer to get where you want to go.
Absolutely. Yeah, I love that. That was really, really a good point, because literally that is the majority of that. I would say the prospective patients that are really looking into stature lengthening, at least, is that group of athletes or people who are physically fit between the age range, which typically you would expect that to be the case. Obviously, after they attain their length and, you know, they are approaching the end of physical therapy and rehab, can you tell us a little bit about the process of when you know it's okay to discharge a patient, and what type of expectations do you set in place for like their new normal? Because obviously they're not going to be the same. There's center of gravity is going to be different. Their biomechanics a little bit shifted and altered. What type of things do you say, hey, look, you're going to need to continue doing this, or you know, expect that this is going to be the case. You can get back, you know, to what you're doing, but it's going to be different. Do you kind of like place that into the head of your patients?
We do. Okay. So one of the hard and fast rules that we have is that during the distraction phase, they need to stay at our center.
Okay.
Because as we talked about early on, not many therapists are exposed to limb lengthening. Not many therapists know the process. And it could be disastrous elsewhere. So we want to get them through the distraction phase, because that's when a lot of the problems can happen.
Okay.
And when they finish the distraction phase, you know, different people do so with different issues at the end of it. So some are extremely tight. If they got 8 centimeters and maybe they're doing both the femur and the tib fib, whether it's unilateral because they had a really big limb length discrepancy and it was in the femur and the lower leg as well, the tib fib, or whether they're doing a 4-segment lengthening because they have a form of dwarfism, or they're undergoing stature lengthening. So with that large of a lengthening, you're not going to get through it and have perfect motion in every joint. You'll have functional if you're at our center.
Right.
But you're going to have some residual stiffness.
Okay.
So some choose to stay longer with us until they get to a better place. And some go back home right away. And that's, as long as they're safe, that's fine. If they've got too much stiffness, Dr. Paley or Dr. Feldman or Dr. Robbins or Dr. Shannon or whoever's the physician in charge of that one, they're going to say, I need you to stay another 2 weeks.
Okay.
But our therapy department does quite a few things to help this transition to home. One is we want to make sure that the patient and their family, if it's a child or if it's somebody who's brought a family member, knows what to do once they leave us. We also prepare videos and handouts for the hometown team. So as you go back home, you're going to get either, not a DVD now, but usually you get a Google Drive link that'll take them to all the videos that we've made. Okay. And now, you know, it'll seem like I'm digressing, but there's some nice things, not nice. There's some positive things that have occurred with COVID. One of those is telemedicine.
Yes.
So telemedicine has been very, very helpful for those that are transitioning home because we provide all those Google links and all those stretches that they're doing as they leave and the exercises that they're doing, but I can't give you per se the next ones, or I can give them to you and I'll say, don't do this yet until you've been cleared.
Okay.
But then, you know, I can now follow up with the patient and see how they're moving and prescribe new things that are specifically geared towards them.
Wow.
And it's pretty awesome. You know, I've got some folks in London, some in Russia, some in other parts of the world that had to leave because of COVID early, and they were in the midst of stuff, and they really wanted to stay another 3 months, but they had to leave, or they you know, the borders were closing, and they left. And so then we continued on with some telemedicine. And they've done amazing. I didn't think, I was skeptical. It's like, how do you do physical medicine over telemedicine? But it's,
Wow.
So anyhow, so we prepare them with their electronic videos and whatnot to go back to their home team.
Wow.
And then they're going to be following up with the doctors, whether they're doing it virtually or whether they're flying back into town and having, you know, a follow-up appointment. And then they're given the next phase. And at that next phase, then they're able to progress and go to the next level.
Wow. That is super thorough. I think that you guys really, you're not only from the surgery, I mean, obviously you have the best, you know, surgical techniques, surgeons down there, but then you have also an amazing, pretty much, I'd say 3 months of right after for lengthening patient, they stay on site at the Paley Institute. And then when they go home, you're covering that basis too. You're making sure that from the moment they step into the operating room to when they're resuming their normal life, they're taken care of. That is like a one-stop shop, streamlined process to get them from point A to point B. Wow, amazing.
Not everybody needs that intensive follow-up afterwards. So a lot of people, once they go home.
Yeah.
So not everybody's going to need telemedicine. Some people have a great team there.
Okay.
And with the guidelines that we give, they don't need to come back and have follow-up with our department. They do with the doctors. You know, but we are there to answer questions. There's many times that we chat with the therapist. We can also now FaceTime in if that's what they want, or WhatsApp in with a session with their therapist with, you know, while they're in therapy. It's not that common. We don't do it that often, but if they request it and they want that, you know, we do that. We follow them through. They're our patient, whether they're in our department or whether they're back home, because we want them to have a successful outcome. And
I think that, some, like you said, after lengthening, some people, they can take it and run with it. You gave them the ball, they can run into the end zone as long as they have that momentum going. They say, hey, I know my consistency. I got to do therapy at home on this schedule. And they're pretty good about it. A lot of the athletes, they take that mindset and they go with it. But Dr. Guardo, is it important that a patient be somewhat flexible before the surgery? Do you say like, and if so, how far out from the surgery do you think that they should really maximize this? Or is it kind of like a whatever, it's like you're going to get tight regardless and we'll take care of it when it happens?
Yes, it's helpful if that they're flexible before, for sure.
Okay.
If you come to us and you have really tight hamstrings, it's going to make it more difficult.
Right.
Or you have really tight gastroc, okay, gastrosoleus.
Yeah.
It's going to make it more difficult. It may also mean that you need to have a soft tissue release during the time of your surgery.
Yeah.
So that happens. They can do that. The iliotibial band is one that is, it's like a tether during a femoral lengthening. And he may release that. That may be part of your first surgery.
Okay.
That doesn't mean that you never have to stretch it.
Yeah.
During the process.
Right.
It will tighten up again.
It'll reconnect. Yeah.
So again, and that's one thing that we have, because we do so many lengthenings and for a variety of reasons, we know which patients are going to be more apt to become tight in which area. Okay. And if you're a child or an adult with congenital femoral deficiency, CFD, and you're lengthening your femur, your adductors, the ones that bring the legs together, have the ability to get so incredibly tight that they could dislocate your hip.
Oh my God.
So we're not going to be stretching you into adduction for your ITB. There's other things that we'll do. And they'll almost invariably, if they haven't had their ITB either removed with their prep surgeries, they'll almost invariably have it released. But if you're undergoing a stature lengthening, you're not going to be at a high risk of those adductors getting tight. You're going to be a really high risk of that iliotibial band getting really tight, and your legs are going to have a hard time coming together. So you'll walk with a wide base of support, maybe internally rotated, hips slightly flexed. That honestly, now that there's more weight bearing, that you don't see the same level of that as you did with PRECICE back then. But so we know what population is at risk of which muscles, which tissues becoming more tight, based on their diagnosis, based on their history. So if they know the patient, if the patient knows that they're going to undergo a lengthening, it's going to behoove them to have the best range that they can beforehand within limits. You don't have to have hyper flexibility, but you do need to have it. It is helpful.
Yeah. Okay. That's amazing. Yeah. Cause I know a lot of people are like, oh, I'll just stretch for, 6 weeks. I'm like, well, you probably want to make sure you get the muscles ahead of time, like 6 months at least, make sure you have some,
and it's also important to have a pretty good, if you can, pretty good level of strength, flexibility, and endurance. Lengthening is a marathon.
It is.
It's a marathon.
It is. It's over time. And a lot of people, you don't understand. You have one therapy today, you're going to have another one tomorrow. It's like, oh, you don't just rest like a workout. It's like, you don't skip days. And what about like nutrition? Do you guys recommend just advice, or do you just let them eat what they want? I think that optimizing nutrition, for me at least, it helped me kind of recover from the therapy sessions. I felt kind of beaten down. I mean, as I approached my length, and by eating and optimizing nutrition helped me recover. Do you guys give them any advice on that?
Well, they do get like a cocktail of vitamin D and calcium that the doctors prescribe. So for bone healing, that's helpful, and not only helpful, it's really necessary. And obviously growing, 8 centimeters or however many centimeters you're growing, you're going to need some protein. So it's important to eat protein as well. We don't have a specific diet that we recommend other than a healthy diet. Coming into the process with a healthy body weight is also really helpful too. The heavier you are, the more it's more difficult for everything. It is in general for whatever you're undergoing. The more body weight that you're carrying around that's not lean mass, it's harder.
Yeah.
Harder.
Around.
So, but that's, we take people of every, with it, as long as they're healthy enough. But I'm just stating, you're asking a therapist.
I know.
So, but in general, dietary, we encourage a healthy diet. We encourage not eating too much too many empty calories. We definitely, you'll need more protein than you normally need. Do you need to go crazy and take protein shakes and everything? No, I personally am a proponent of eating real food.
Whole food first.
I worked in weight management before and cardiac rehab before I even worked as a therapist. So in my back days as an exercise physiologist, I ran a cardiac rehab program. And I worked in weight management. And I'm a big believer in eating real food, eating wholesome food, a variety of food, and in moderation.
Absolutely.
And what changes with that during undergoing limb lengthening is that you are going to need more protein than you would need if you were just living your life.
Absolutely.
But I'm, again, not a proponent of saying taking huge amounts of
because your activity level has dropped significantly, so you won't need all that. So on to a really interesting topic, because of the fact that we know that when patients undergo limb lengthening, whether they have a discrepancy, CFD, congenital femoral deficiency, or they're going for stature lengthening, you mentioned earlier that different muscles get tight depending on what condition they have. For example, you said some stature patients will have more of a waddle, like a Trendelenburg gait, or what is the average time frame that you see for each of these different patients for them to resume a normal walking gait? Or let's say for CFD, obviously a patient who has that, they have to go through a few surgeries and go through some stuff, but when they start walking, they're finally balanced out and the discrepancy is fixed. When do you see from the surgery to when they can start walking normally? And the same thing for stature lengthening.
Well, for someone with a deformity, like congenital femoral deficiency, it takes longer. Obviously, their anatomy is not like yours and mine. They may always have a little bit of a difference, even when their legs are to length and normal, or rather equal. They may have a slightly different gait. And it depends also on the level of deformity. It depends on how much work they've done along the way. So those that have worked really hard throughout the process and maintained muscle are going to regain that more quickly. And also, I say regain, they may never have had it, right? Because they may never have been to length, or if they've lengthened episodically, they may be to length and then they grow out of it, to length and then they grow out of it. So we see a lot of that. But it depends a lot on the level of deformity, because there's CFD, and as you may or may not know, there's so many different types of CFD. There's a 1A, and there's a, there's really mild, and then there's really, really severe. So it depends on their level of deformity and their level of activity throughout. We have folks that are amazing athletes despite their deformity. I have, he's not a kiddo anymore, but when I first met him, his name's Mauricio Iga. I can say that because we've presented together and whatnot, and he's a champion swimmer.
Wow.
And he's been a patient of Dr. Paley since he was 2 or 3.
Are you kidding
Started
me?
in Baltimore, ended up with us. He's now a physical therapist.
Very cool.
He literally a champion swimmer. He went to college or high school, college, and all that on scholarship. And I think he was in line for the Olympics at one point. And now perhaps Paralympics, but everything's on hold right now. But anyhow,
Yeah.
so he's now a physical therapist. You will not see a limp on him. And
Really?
he, I believe, has lengthened over 18 centimeters in his leg. I can't quote you the amount because I don't remember. But you will not see him walk down the street and go, "Come, you won't come. You won't come."
Wow.
And he does everything.
That's so cool.
And then you'll have folks that have more of a limp.
Yeah.
That have levels of deformity that are more severe. Not to say that his wasn't severe, it was.
Mm-hmm.
But I mean, it's a variance.
Right.
So, but if we're talking about somebody that's got a shortened limb, maybe because of a growth arrest, maybe they fractured a femur as a child, damaged the growth plate, and ended up with a limb difference.
Right.
They honestly usually recover their gait so much more quickly because everything else was, I hate the word normal, but it was normal.
Right,
They had the normal musculature, they had, and their limb wanted to be to length.
Yeah.
Something happened.
Right.
So their tissue it's not as tight in general.
Yeah. Unless
they had a really big injury that, created a lot of scar tissue. So everybody's unique and everybody's different, and as is the rehab.
Yeah.
Go to somebody that's undergoing stature lengthening. That is a more typical, progression because their anatomy is normal. They underwent lengthening to become taller because, and that depends so much on what they put into it.
Absolutely.
If they put in 100% and they follow the guidelines, I am seeing literally, I am seeing folks that leave our center that are walking very, very impressive with very little deficits.
Wow.
They're weaker, of course.
Yeah.
And they'll gain that back over time. Their anti-gravity muscles are weaker.
Yeah.
But those that really work hard.
Yeah.
Yeah. And I'm also seeing people that maybe didn't do everything they're supposed to, and they're struggling,
Yeah. Right.
So it depends on what you put in, how much you're getting.
Yeah.
So if you're lengthening 4 segments or 2 segments based on, femur to fib.
Right.
It takes longer, it's harder, you're growing more tissue, but it depends so much on what you put into it.
Yeah.
So much on what you put into it.
I love that you brought that up because of the fact that I made the point. I said, and Dr. Paley said the same thing. It's like the surgery is just the surgery, but then, and then your therapist got to be good, but then obviously what you do, the patient compliance is a huge portion of this because people think, oh, I'm just going to pay money, get this procedure done, and I'm good to go. No, you got to invest your time, work, blood, sweat, and tears in this to make sure that you're successful on the other side. So that's amazing. Dr. Guardo, people love seeing progression and, basically love to see testimonials or how people are walking. Do you have any type of footage or anything that you can show publicly of what you guys kind of do at the Paley Institute?
We definitely have some videos for you.
Okay.
They're not of folks walking. What you're really going to see are some videos of some of the exercises that folks are going to expect when they come for a lengthening.
Absolutely.
And so what I've prepared is our videos rather for folks in the middle of a femoral lengthening and then in the middle of a tibial lengthening.
All right. Very cool.
So, so the first video I'm going to show you is a gentleman who's undergoing a femoral lengthening due to an injury. And this is Mike Thompson. He's one of our amazing team. He works a lot with, he works with everything. Most of our therapists do, but he also sees a lot of our stature patients.
Okay.
The gentleman here is not a stature patient. He has a limb difference due to an injury.
Okay.
Let's do some short arm so straighten out your knee. As you can see, he's got a little bit of a knee extension lag. That's pretty common with more lengthening. The quad does get a little bit relaxed. And do it again. The quad does get a little bit weak, and that's a good sign of him not able to get his knee fully into a knee extension on his own. And we want to try to work on that to make sure he can do that on his own, because that makes our job a lot easier if he can do it himself. So because he's going into it multiple times a day instead of just being going into full knee extension when we're pressing him into that, or when he's stretching. Okay.
So as you could tell, it's the COVID era, so we have to wear masks. Everybody in our center is wearing masks. So it's hard to hear him. Were you guys able to hear him?
Yeah, I could hear him pretty good, but I'll make sure that I turn the volume up there.
Okay. All right. So he was talking about how the quads can become weak. And if you're not able to fully extend your knee, then your hamstrings are going to get tighter. So he was talking about how that's one of the beginning exercises that you're going to get, and you're going to need to do it throughout the day. Okay.
All right. So knee extension is the main thing that we want to make sure that you can maintain 0 degrees knee extension. If you can maintain 0 degrees knee extension by himself, that is the best thing. But as you get longer, you may get a little bit tighter, so we may have to start doing some manual stretches. And I do want to try to make sure he can maintain his natural knee extension. So if he has a little bit of maybe hyperextension, I want to make sure he can kind of maintain that hyperextension. But I mean, I don't want to excessively press him into hyperextension if he goes like 10 degrees. Okay.
Very cool.
All right, so this is going to be a 90-90 stretch. I like to have this one named down so I don't have to hold it like that. But I can come in and kind of just face his leg and the knee. So I like to hold the leg like this, kind of clasp my fingers together. And as I extend up on it, put some pressure, some back pressure on his knee. Make sure it's not up. Everyone is a good stretch.
Wow.
So this is like a typical 90-90 stretch. Trying to stretch those hamstrings. Like I said before, the hamstrings and the knee extension is very important. And it's usually, especially on guys, it's usually what gets tightest, and that's usually our focus.
So let's take a second to talk about some of the things that are going on there that to us are just part of the way we practice. But he's got his hips in an opposite position. Okay. So if you try and stretch the hamstrings without bringing the other leg down, what you're getting is lumbopelvic movement.
Okay.
So he's isolating those hamstrings by bringing his contralateral, or his lengthening side is his left, his non-lengthening side is his right. He's got his back flat, so he's got his pelvis actually in a posterior pelvic tilt. Then he's brought the other side down, and he's also straddling his leg that's down and holding it there with his legs.
Okay.
Okay, so it just looks like a guy doing a hamstring stretch. There's a lot of thought going into that that I don't even think Mike thinks of anymore. And we start training them day one when they come to us.
Yeah.
And when a new therapist comes to my center, I don't care if they have 20 years of experience. They're going to train for weeks before they're seeing their own caseload. They're not going to be touching patients until they've observed for at least a week.
Wow.
And then they're going to start doing co-treats. And then they're going to start seeing them on their own. But so Mike does these things automatically. Another thing he's doing, this guy has already been through the active warm-up. He's already been through all that. And then you saw him do the quad sets, which started to activate the quads, which reciprocally inhibits the hamstrings. Then you saw him doing a short arc quad. Now you're seeing him do a 90-90. What he also didn't show on here is before this stretch, he was doing this position by himself, actively extending his knee. So there's been a whole bunch of prep before we're even here. And then Mike has got him in the position of opposites at the hips. So we're getting a better stretch on that hamstring, and he's going up incrementally and slowly.
I see.
So, so there's a lot of background before you even get there. And one thing I personally will do is I will hold that stretch, and then I will have them, okay, now I want you to give me a little bit more. Can you extend that knee a little bit more? I'll follow you up. I give them as much control as they can have, and I try and capture it then. Once they go up, I'm not giving back. I got you. But you got there, but I'm going to hold you there. So then so as they actively extend that knee using their quadriceps, your body has this amazing wiring that you reciprocally inhibit your hamstrings.
Wow.
So you let them go a little bit, and now we get you a few more degrees. Now I'm just going to hold you. It's hard. Yes, breathe through it. Take a breath. Okay. Hold it for 10 seconds. Now I want you to do it again. So now they're going to kick up a little bit more, and then we're going to hold them there. We're not going to give it back. And we're going to continue that little dance. Until we've reached the end.
I see. Wow. That's amazing.
We'll let them go down, and then we're going to do it again. So we're going to do it 3 times and then move on.
I see.
And that's one of the hardest stretches for somebody with tight hamstrings. That's the beginning stage of it. And then we're going to do that little dance to get more and more and more. So
yeah, I definitely know that stretch got me the most. I remember even if I did tibial lengthening, that one, it's like obviously the muscles are kinetic chain, so that was really a hard one for me too.
And so, well, let's also talk about the other structures that are stretching with that.
Yeah.
Yes, of course, your hamstrings. And if you're doing a tibial lengthening, of course, it's your gastroc too, right?
Yeah.
But what else? What other structures can be really uncomfortable?
In that movement, I guess the glutes, lower back, maybe, or gastroc crosses the knee joint. You have, let's see, a
really long structure.
IT band, or no, quadriceps? No, not quads.
The sciatic nerve.
Oh yeah, the nerve. Yeah.
So nerve has to grow also.
Yeah.
And that can be really uncomfortable.
Yeah.
And so here we've got, if you look at his foot, his foot is on, or his ankle's on slack. Okay, so it's in plantar flexion right there.
Right.
But so if he were lengthening both segments.
Oh yeah.
Right. Even not lengthening both segments, even just lengthening the femur, I would probably do some sciatic glides there with the foot.
Yeah, with the dorsiflexion.
Yeah. And so, you know, you're still getting that sciatic nerve, and that can be part of what's creating, or rather contributing to, the discomfort of this stretch.
Absolutely. I do remember that now that I remember I'd feel like a sharp pain that would run through, and that was the sciatic nerve all the way to the bottom of the heel, essentially where it runs.
A lot of people miss that because they're thinking muscles, tendon,
ligaments, all this,
fascia, and all of those are true.
Right.
You also have to think nerve.
Nerves, huge.
Everything. Yeah. It's all. Okay, so I think we talked earlier in this lecture, or not this lecture, but this interview, about preparing the tissue and the joints, the one joint muscles before the two joint muscles. So you're going to see that here, he's going to do stretch of the shorter quads before he goes to the longer quads. Okay. So I'm going to resume.
So like I said, for femoral lengthening, knee extension is usually our main focus, but we do not want to neglect knee flexion. I usually start knee flexion in a sitting position, but also he can do active knee extension, knee flexion. So kick on the quad, try to keep it strong, and then bending, use the hamstrings, not only to strengthen the hamstrings, but also stretch the quads, so you do that as a warm up. Then we'll come over here and make sure that the femur is down, and I'll push the foot underneath the bed until I tell it to stop. And as long as you're not on the ankle, you're about mid-shin like I am, and the hip is down. Actually, drop the hip down a little bit. There you go. So the thigh, the femur is fully supported on the bed, you're safe. An alternate way of doing this would be to stand up, so if he's maybe a little bit tighter, I can come in like a lunge position. I again try to sit down a little bit more toward that right side. Or my right side, your left side. I'm just going to drive my knee into it. And stop.
Wow.
So again, like I said, as long as the thigh is fully supported, you're pretty safe in doing this one. The only stretches are going to be 3 times 30 seconds, usually 3 times a day, so 2 of them is usually on them, and except the weekends where they got to do 3 by themselves anyway. Right?
Amazing.
So a couple things with this that, again, Mike's not even talking about because it's second nature to him, is he's using a short lever arm. So he's talking about his hand being up higher on the tibia. In another facility, they might do that stretch and bring their hand down to the ankle. And that would probably be fine for that facility. But because in the process of lengthening, soft tissue becomes tight and hard tissue, or soft tissue becomes harder. So muscle and fascia and whatnot become tight. And the bone, you know, you're getting that distraction and you have some wispy bone in the middle as it's, you can actually have some problems if you use a long lever arm. So like if you want to change a tire or move a heavy rock, a long lever arm is important.
Right.
But if you want to stretch a very tight joint, you want to use a short lever arm so you're not doing any damage to the tissue and to the bone. So he's using a shorter lever arm to protect the bone.
The bone,
yeah.
That is amazing. And like you said, other centers may not know that, but the patient would probably, like you said, is going to be able to tell the therapist if they feel pain, which Mike was very, very communicative.
Yes, but we also incorporate that in the videos that we make. We talk about short lever arms. We talk about avoiding long lever arms. We talk about those things.
Wow, very cool.
So I like to have them do some hamstring curls here, just to kind of warm things up in the knee. But you can...
Again, activating one muscle group to inhibit the other.
Of course, you should be working on his glutes too. So if he's got weak glutes, he's more likely to start doing this because he doesn't have the strength for his strength, right? So I don't want to have him get tight. You know, he might be sitting a lot. So I do want him to try to do some hip extensions and then flexions to lengthen this muscle. Okay? So, but also we need to stretch it in the knee. You tell me when to stop. So I don't want to be down here at the ankle. I want to be about mid-shin. And make sure the thigh is fully supported on the bed. I'm going to be pushing in. Tell me when to stop. If it's an easier stretch like this, I do like to have my elbow back by my hip. I just kind of use my hip pressure right now. There is another technique I like to do. If it's more of an aggressive stretch, I usually use a towel here. I'll rest the tibia right in my elbow and turn.
Very cool.
So one thing in this position, he has his leg just slightly abducted. If you see that. Their legs are not parallel, they're slightly abducted. And so the first stretch or second stretch may be there, but then you want to bring them parallel. So that one allows, it allows that ITB to not be on full stretch at that point. So then we bring them together and we repeat the same stretch. So when the legs are parallel and they're running parallel, then it's going to be much more difficult to get your full knee motion. And you notice there that gentleman is getting 90 degrees very easily.
Yeah.
In the midst of his femoral lengthening, and he's getting it quite easily, and that's very impressive. He's actually going well beyond that. So, you know, we don't want to ever lose 90 degrees. We want to keep functional motion. That anyhow, he's tolerating it well, but the next stretch would be with the thighs parallel and getting a little bit more of that ITB.
It's all about that progression. And I see he's using that short lever arm that you were talking about. Very cool.
So he was explaining that if he had to go more forcefully, he would do that one. Now let's also appreciate that Mike is 6'5", and so things that work for him are going to be different than, say, what I may use. Or what I've got a therapist that's not 5 foot, that
Oh, wow.
4'11". So each therapist is going to have a little bit different mechanical advantage that they're going to use.
I see.
And, yeah.
Amazing.
Okay. All right. Okay, so this is a patient that's undergoing bilateral tibial lengthening. This is actually a stature patient, and not lengthening the femurs. And so Mike's going to take you through a couple things that are important there.
Okay.
So the patients that have stride, their weight bearing is tolerated, so you can do a single leg stretch. If need be, his knee is a little bit bent, so I recommend putting my hand just below the patella, right on the tibia, and kind of push here, push all the way to full knee extension. And he can use his anterior tib to pull up, which should draw that heel down. Sometimes I will have to come here and here, I'll push that heel down. So I just got to switch positions with my hand. Still pulling on the tibia to get the knee all the way straight. That's fine.
Excellent. Wow.
So again, talking about the progression, you can see, or maybe you can't see, but the wedge is at one of the lower settings. So he may repeat that stretch 2 or 3 times and increase the angle of the wedge each time.
Okay.
So that's that progression. Each thing builds to the next.
Let's see. Wow. Yeah, I remember that. For my tibial lengthening, they went up. I think I may have reached 40 degrees, but 30 degrees was like my comfortable zone.
Right. And he's manually assisting with that. So he's doing some other things. It's one thing to stand on a wedge. It's another thing to have someone help you gain that full knee extension and hip extension, and I also will grab that little calcaneus and pull it down. So to get all of those movements within the kinetic chain, it's very different than doing a wedge stretch by yourself at home.
Wow, that is amazing.
Things I also wanted to mention in here. Again, it's the COVID era as we're having the, and my department has been operating throughout. We did not have one day that we were closed because we've got folks that are lengthening or correcting, and once you start that train is rolling and you can't get off the track. So we had to continue, and we were there to support our patients throughout. We've made quite a few modifications. We're socially distancing to the best of our ability. So you're seeing beds in that room that aren't being used at certain times to give distance between. We're seeing over 100 people a day, over 100 patients a day in my department.
Wow.
And, we've, thank God, and knock on wood, have not had any transmissions within my department, and we're busy. So we are socially distancing. It may not look as pretty. We've even got some beds in the hall. We don't love that, but that's how we can see this many people, provide this care, and keep everybody safe. And you do see the masks, and you do see the gloves, and everybody gets a temperature screen, and everybody gets hand sanitizer as they walk in. So it's not as pretty as it was because, again, we're distanced and we're doing the best we can. But I just wanted to point a few things out. When we're not in the midst of COVID, we don't wear masks and
Right. No, I think that's a very important point. Yeah.
Pray God that at some point in the future, when people are viewing this, they're going to say, why do they have masks on? I can't imagine.
Right. They're like, is it Halloween there? Is he a ninja? It's like, no.
Yes. Okay, so let's go on to...
For the gastroc, I usually like to use a towel because I don't want to have my wrist and that much flexion. Hold it down here, at the back. I use this hand to control the inversion and eversion. I usually do like to use it in the back of my leg, or I'll just kind of drop my weight. Tell me when to strip. Stop. Good? With this one, I do want full knee extension. So if I need some help, I'll have somebody help push the knee all the way to full knee extension. But this one is for the gastroc. So like I said, I need full knee extension with this one.
So he also has his calcaneus cupped. He didn't mention that, but I can see it. I know he does. And he's distracting a little bit. He's also making sure that the calcaneus is not going into varus or valgus. Because if you've got a tight gastroc and it cannot accommodate that level of ankle dorsiflexion, it will escape into valgus. And it won't get the same stretch you want. So he's got that cupped in his hands. He's providing that stability so we don't escape into valgus or varus or so that he's in the right position. So all these little tricks that he's just automatically doing and that my team automatically know to do. And sometimes we almost forget to explain. And this is beyond the scope of explaining all those little things.
Right.
Those are the things that you're going to get at our center that other centers may not know, they're not going to know that this is going to happen because they're so tight because they've lengthened so far. So anyhow.
Yeah, I think that's a huge one about escaping into varus or valgus. I didn't even know that, but I remember my therapist would do that too. They did cup it, but that's a huge point because if you're just stretching the foot and it escapes, you're losing the stretch altogether.
I go back to what I've said. Movement will take the path of least resistance. And you have to know those things to look for those things.
Is the main focus, especially if they're all four segments or both segments, top and bottom. The hamstrings will pull, and so the gastrocs will pull. So knee flexion is what we try to limit. Really focusing on the knee extension, trying to get that full knee extension, particularly with that gastroc stretch, and that can be really, really tight. But knee flexion should not be neglected. Anything that passes that osteotomy site can get tight, especially those two joint muscles like the rectus hamstrings, and gastroc. So really focus on those muscles with any of the ligaments. All right, thank you.
Wow. Dr. Guardo, you're also ASTYM certified, and I know from my personal experience that ASTYM is like a very useful treatment modality to help break up scar tissue and adhesions to increase that pliability of the soft tissues. Do you have this as part of protocol or only for patients that actually need it, for their therapy?
Well, most of my staff is ASTYM certified.
Okay.
I did an extensive review of all the various soft tissue tools and whatnot. And we played with a few and we chose, and also I spoke with Neil, who runs the Rehabilitation Institute's department. And he was a very big proponent of ASTYM over other ones. And so after all the background that went into it, we chose ASTYM. And so we've brought them into our center a few times to do kind of a massive training of staff. And we use ASTYM. Not every single person gets ASTYM because, some people have risk factors. You're always looking at what things each patient needs. I am a huge believer in ASTYM. I have seen it's a game changer.
It is.
And it's interesting how, which we'll discuss in a minute, but other things that we've used, other conditions that we've used it on, that it's just like been a game changer for those conditions as well. Anyhow, I think the more tools you have in your box, the better you can treat that patient.
Yeah.
So that was definitely a new tool. Does every single patient get it? No.
Okay.
If you have a risk, like if you have hemophilia, you don't want it because it can cause bruising. And if you're on anticoagulants, it can cause extensive bruising. So it doesn't mean you don't use it on that population, but you start light.
Okay.
And you see how they respond.
I see.
There's some people that are not good candidates for it. Older folks with very thin skin, not great candidates. But most of the population that we see are great candidates for it, and lengthening patients are excellent candidates for it. We use it on, I would say, 95+% of all of our lengthening patients.
Wow.
We see kids as well. So we also use it on kids that are lengthening. We also see a population called folks with arthrogryposis. That's a condition where there's multiple stiff joints. And having worked with limb lengthening patients who get really, really stiff, and we were really good at dealing with tight tissue, the more we started seeing the arthrogrypotic population, those skills transferred over, and we've been able to have amazing results with them. And I'm using ASTYM on babies that are weeks old with arthrogryposis, and it makes a humongous difference. So I know that's not the focus of this, but I just wanted to mention it. Our center is one that often thinks outside of the box. Everybody at our center is quite progressive. If you have a hard time with that, you're going to have a hard time working at our center. If everything's really rigid in one certain way and you don't want to, it's going to be hard to work here. So anyhow, when we get a new modality or a new treatment, then we're going to start, just our brains work that way and our colleagues work that way. We're going to start thinking about, where else can I use that? What else can I do with it? And so that is one of the absolute most fun things about my job, as well as I get to do that, and we get to have an impact on so many different conditions that are treated very differently elsewhere.
Absolutely. I think that you guys have a top-notch rehab center. It's at the world-renowned Paley Institute. But can you give me like an overview of how your team is structured? I know you're the director of the rehab center. You have great therapists like Mike, who we just saw. Obviously, you mentioned a few others. Can you tell us how many therapists you have? Do they treat different conditions, or are they? Each of them have different, skill sets, or can you just tell us about the whole tier system of your department?
Okay. So I'm the director. I still see a caseload. I have 30 therapists.
Wow.
More than that right now, honestly.
30?
We have a lot. And we're adding more because, we have a lot of patients we see. I have occupational therapy. I have 3 occupational therapists.
Okay.
And again, adding more. And I have, because we see so many, and we want to make sure not everybody's full-time. We have a lot of full-time therapists, but we also have some per diem therapists as well, because like I said, we don't have a waiting list. If you need therapy, we're going to get you in.
Okay.
Whether it's COVID, whether it's anything, we're going to get you in. So I need to have a team that can work seamlessly, relatively seamlessly. We do our best for seamless. That's our goal. And so everybody gets the basic training. Everybody needs to be able to treat somebody that's lengthening.
Okay.
Because we see so much of it at our center. So again, folks start at our center, and I don't care how many years of experience you have, you're going to still undergo the basic training for limb lengthening.
Okay.
Everybody treats that. Everybody should be semi-comfortable with children because we see a lot of kids.
Right.
And everybody should be comfortable with adults. That said, there are people who are much better and enjoy peds, and that's what their passion is, and they want to work with peds. So they're going to be seeing more of a pediatric population.
Right.
And then there are some that are more comfortable with adults, and they're going to be seeing more of our adult patients. But, if somebody calls out sick, or if somebody, gets whatever, they need to be able to go back and forth. Okay. We do respect, if somebody's very uncomfortable or hasn't worked with infants, we're not going to put somebody with an infant that hasn't worked with infants. Okay.
Right.
not going to do that unless they want to, and they're going to train first before they do it. There's so much training in my department. There's so much training. Yeah. A lot of the therapists that came to me were not pediatric therapists, but they were willing to take that extra step. Okay. So I'm very, very proud of saying that we have, like, Mike's a great peds therapist now. Yeah. He never taught kids or never treated kids before he came, but he is well loved by the peds that he sees. And obviously he's a great adult therapist. You know, I have some that are better with certain ages than others. You met Miss Dale the other day. Yeah. I call her the toddler whisperer. She can get a toddler to do anything and be happy they're doing it, pretty much. But so yes, we all have different specialties, but we all see a little bit of everything as well, and everybody sees limb lengthening. Gotcha. And would you say that because of that, you know, that really, I guess, standardized training that you give each physical therapist that comes there before they even see a patient, do you think that that has something to do with your amazing track record of success? For sure. Yeah. Yeah. For sure. 100%. And I also think that, you know, if somebody moves on, as people do, right, the skills that they've learned at our center are going to be very applicable anywhere else. Absolutely. You learn better how to treat soft tissue. Yeah. You're going to be a great therapist somewhere else. You learn how to, you know, treat orthopedic deformities. You're going to be better somewhere else as well. So I'm very proud of my team. I think the training is imperative. You know, it's expensive too. It's a lot of money to train them to be this level, but the proof is in the outcome. Yeah, it pays off. The reputation precedes itself. So that's amazing. And Dr. Guardo, not only do you train the therapist, but you also, like you said at the beginning of our interview, you also teach an annual course for physical therapists and medical professionals so they can be well-versed in this procedure as well. Can you just give us a little bit more information on that? And you said it may not be this year because of COVID, and that's understandable. But can you tell us, like, basically how the enrollment is and how, you said it's a week long. Can you just give us a little bit more details on it? Absolutely. So it's a week-long course. The first 3 days are didactic, meaning you're going to get the lectures and the background. And then the last 2 days are like a little mini preceptorship where you can come in and it's great because people that work with specific populations, we've always got so many lengthening patients there that, or so many deformity correction patients there, that we can almost customize what you're going to observe. So if you're all peds, you can do that. If you're working with stature, we've always got a fair amount of stature, and you can, we can cherry pick which patients you're going to observe. The first 3 days of the course are going to give you the basics on first deformity correction and limb lengthening, and also what conditions are going to be treated. What is appropriate for this? And a little bit about the history of those and about the background as to what things are going to be more problematic in a patient with CFD versus a patient with a growth arrest, and a patient with a fibular hemimelia versus tibial hemimelia, in a patient with arthrogryposis versus limb difference. So that is going to be part of the course. We're going to give you the rules of the road for limb lengthening, talking about short lever arms, talking about preparation, talking about soft tissue tools, talking about pain management. Huge. That's anxiety huge. Management. I have child life. So we have child life specialists as well at our center. And I have them come in and talk about managing pain and anxiety. Some of the different things, like we'll use virtual reality to take them out of their body and put them into their head. Wow. And take away some of the pain. There are some pain studies on that, and honestly, for a child, even for adults, the first virtual reality came from war veterans who had been burned in the war and were undergoing debridement, and they used the virtual reality to decrease their pain medication. Amazing. And so we now use that on kids, And even if you're not using the whole virtual reality getup, we've got an iPad ready for whatever person needs it, whether an adult or child, because the brain is huge and very powerful. And the more you can help to refocus, whether it's on breathing, whether it's on escapism, you know, through something healthy, we're going to use those things. So anyhow, we talk about that during our course. We talk about, you know, all the specifics for the different types of lengthening, the different devices, what's going to be more problematic with an external fixator versus an internal fixator, the types of bracing. We have OT come in and do a presentation on bracing alone, because you do have to brace during lengthenings.
Right.
You do have to also know what braces are appropriate for what populations. Some of them need custom, some of them can go with off the shelf. We do bracing. We make braces in our center with our OTs. Right. We talk about upper extremity lengthenings. We talk about femoral lengthenings. We talk about tibial lengthenings. We talk about four segment lengthenings. So we walk you through each different population and each different thing. And then I do a lecture called Pitfalls of Limb Lengthening. And we can talk about all the different things that can go wrong and will, if, you know, it can. You have to know not only how to do something, but you have to know how to fix something, recognize something when it's going wrong, and quickly adjust.
Wow.
If you don't know that, that's where things can go very wrong. We see, as therapists, these patients far and away more time than anyone else in our center, because we see them an hour a day, 5 days a week. So we catch a lot of things that are happening before anyone else. Right. We catch, I think we have a pen site infection here. And so, you know what, we can seamlessly send a photo and a text down to a PA or a doctor. If it's not, you know, if we were just a little suspicious, it's going to a PA. I've had patients come in that have quickly develop something, and it's pretty scary how quickly something can happen. And I take a photo and I'm sending it right to Dr. Paley, and that patient can be taken care of in a 24-hour period. And I've never been anywhere else where I've seen that. I'm sure it exists somewhere, but I've not been. And that's one of the things with our center that helps, you know. So we talk about that during our course. We talk about the pitfalls during our course, and then they get to see all that, and then they get to come over and see, you know, what runs in our center. So
that is very thorough. I think that, and what you just mentioned at the end there, Dr. Paley said something so parallel to that in his interview. He basically said that, you know, making adjustments once you find a complication occur and taking care of it, nipping it right in the bud right there, you can salvage the situation. And he also mentioned that the therapy department and the medical department are so intertwined that you have a seamless integration across the board, so that no patient from wherever they're being seen at the time, whatever process they're in, whether it's therapy or the surgery, somebody knows what's going on. So you guys are seeing these patients on a daily basis. They can catch something, and then the medical team knows, they take care of it, they're back to therapy, and then the process keeps going. That is amazing. I got to give you guys props. Amazing. Well, go ahead. Sorry, I'm sorry.
No, I just said that's the goal.
Yeah, that is the goal, and it is accomplished by you guys. You're doing very well. Dr. Guardo, where can people reach out to you and contact you if they want a little bit more information on your therapy center and treatment? Let's say if they have a kid who has CFD, or a kid who has a discrepancy, or if this person's looking to get stature lengthening, they just want to ask a few more questions.
Well, we have a website that they can go to. I'm trusting you'll post that so that they can see it. And I would say that's a really good place to start. We have a whole team that reviews all of the incoming questions on our website, and then they send it to the correct person. So I get a lot of inquiries being sent to me from our team that's reviewing that. So they can go that way. And then if it's something that's appropriate for someone else in our center, like a physician, or it's appropriate for maybe a patient care coordinator, they can go that way. So I would say come through our website, and there's a whole inquiry section. And if I'm your person for that, you can get to me. Also, my email should be up on that website as well. So, yeah.
Absolutely. I'll make sure to post all of your contact information in the show notes so they can reach out to you with a click of a button. Dr. Guardo, do you have any final words of advice for a patient who is looking into limb lengthening for any of the conditions that we talked about today? And just to kind of like recap your overarching theme that you've really been trying to hammer home. Any words of advice?
Well, I would say do your research. Look at all the different things. It has to be something that I would want a place that's done a lot. Okay. I wouldn't want to, personally, I wouldn't want a family member or myself to go to a place that had done one or two, because, you know, a lot can go wrong. Right. And if you only do a few, you're not going to know that, or you're not going to have managed that. I would also say go to a place that has therapy incorporated. And then if you do choose our center, make sure before you even come that you've identified where you're going to go when you get back home. Because that's going to be important. And when you come to our center, you know, do your research in advance. Think about where you're going to stay. Think about how you're going to get there. If you stay at one of our approved facilities, we have transportation that comes straight from them. If you're a younger, if you have kids and you're staying at Quantum House, you know, you're on the campus and we have transportation. If you're going to stay off at like an Airbnb or another hotel, you know, think about your transportation, think about those things, and prepare. Prepare for maybe a little more time than you thought you might need. If the minimum they've told you is 3 months, you might think about 4. And if you don't have to stay 4 months, great. But if you've only prepared for 3 months, not 3 months in one day, only 3 months, and you're kicked out of your housing at 3 months, and then we have to slow down your lengthening because either you weren't making good bone regenerate or you were getting tired or whatever the reason be, but you had to slow it down and you're still here, and now it's going to be 4 months or 3 months and 2 weeks. You know, if you've thought about that in advance, it's going to be less problematic for you. So think about those things. Think about your insurance if you're a patient that insurance is going to cover the procedure, and make sure you've got an insurance that's going to cover therapy and that's going to cover enough therapy. Know your benefits. Really important. Some people think about, oh, the surgery's covered, great. And they don't look into the therapy, and then they get here and they realize they've only got 15 sessions. And they're trying to, right. So, and some therapies are hard limits and some therapies are soft limits. We are very good letter writers and we are very good at justifying what we're doing. But if you've got a hard limit of 15 visits, you got to know that stuff. Plan ahead. Most limb lengthening is not an emergency, right? Other things come to our center that are, but limb lengthening, if you need to put it off for a year, you can put it off for a year so you get all those ducks in a row. Because you don't want to be hit with the bill because you didn't do that prep work. We want our families and our patients to leave physically healthy, emotionally healthy, and financially healthy, right? So we want to make sure that they have the benefits they need before they even walk in the door, and that they have enough therapy to get them through the process safely, for not only their body, but their bank account as well. So that's really important, I think. So, and also think about your support system, who's going to come down with you.
Yeah, that's huge. I know for a fact that the support system, especially during lengthening, it's a lonely battle, and you know, you want to have somebody to be there with you. So, well, Dr. Guardo, that was an amazing conversation, discussion. Thank you so much for your time, for coming on and sharing all of this insight into the world of rehab which is a world of its own, I think, but works together with limb lengthening. I think you guys do amazing work. I'm going to make sure that I post all your contact information so that anybody who wants to reach out to you can do that. Everybody, that is Dr. Fran Guardo of the Paley Orthopedic and Spine Institute in West Palm Beach, Florida. Dr. Guardo, thank you so much for your time.
It's been a pleasure. Thank you.
Thanks. Well, I hope you enjoyed that informative interview with Dr. Guardo. Not only is she very experienced and well-versed as a physical therapist in the field of limb lengthening rehabilitation, but she's also advancing the field by teaching and training other therapists so they can also be successful with patient outcomes. Well, if you're interested in reaching out to Dr. Guardo or her team, I'll post a link to her contact information in the show notes. Until next time, this is Victor from Cyborg for Life, signing out.